Okay, so we're going to continue our population health across UTHealth Houston, and we're going to kick off this afternoon session with Dr. CiCi Bauer. She's a tenured faculty member at the School of Public Health and holds the James W. Rockwell Professorship in Public Health. She earned her PhD in statistics from the University of Washington, Seattle, with a research focus on spatial and spatio-temporal data science. Currently, she directs the Center for Spatial-Temporal Modeling for Applications in Population Sciences and co-directs the UTHealth Houston MD Anderson Population Health Initiative. Prior to joining UTHealth Houston, she was an associate director of early clinical development research at Pfizer and an assistant professor at Brown University. Welcome.
All right. Oh, thank you. Oh, thank you so much for Dr. Fernandez for the introduction, and thank you all for being here. It's really nice to see many of you in person. So I'm going to start with a couple slides just talking about the campus that we have at School of Public Health. We do have 5 academic departments at School of Public Health and 16 different centers. And also we have these campuses that are spread across the Texas. And in terms of center, we also have many different centers that you listed over here. And for today, what I wanted to introduce to all of you is some of the work we're as a Center for Spatial-Temporal Modeling for Applications in Population Science and how we actually support some of the other centers in their work. And I wanted to highlight a few examples. But at the end of the slides, I'll show you the website of our center so you can learn more about other projects and some other more methodological work and application work, and particularly with some of the work associated with implementation science from our website. So our center is very new and we're a young but small but mighty group, and we established in 2023. And as Dr. Fernandez has introduced to me, my background is in biostatistics. And so by training, I'm a biostatistician, and I specialize in doing spatial temporal data analytic and the visualization. We generally call this data science in a sense that we work a lot from data retrieving to dashboard development, so the whole pipeline related to spatial and temporal data. And the idea that we have is we wanted to use spatial temporal data, which actually most of the data when we collected them will have spatial and temporal components in there, just how we can best utilize this information to uncover some hidden patterns. And we have a lot of applications and projects with other centers in the School of Public Health and beyond. And our application has included infectious disease, cancer research, mental health, environmental health, health disparities, chronic disease management, as well as implementation science. So some of the particular application that I want to show you, we start with one that we have worked during the COVID. This is, again, with the Center for Health Promotion, where we are addressing COVID testing disparities in vulnerable population in Texas using the community JIDI or just-in-time adaptive intervention approach. So there are many, a lot of more detail on implementation science, but I wanted to tell you just about how our spatial temporal data science team has been contributing. So we have been really contributing in these following 3 aspects. One is we support a lot of the data pipeline to help identifying what is the vulnerable population. What I want to show you here is we all know that the trend with COVID epidemic is very dynamic in the sense that it's changing, and there is a we are receiving data as we speak, and then we really need to turn that data into analytical format, and then we can actually use that information to support the implementation science design. So through this work, we actually have developed these pipeline, and then we're connecting all the data we receive from surveillance data in the sense that connected with other social determinants of health data or additional public health databases so that we can help doing the selections. And we have actually worked with the implementation science team in terms of this stepped wedge design, where we could turn these selection or suggested areas for intervention that can improve the testing disparity. And then the implementation science can go to do their work and then actually doing this around, and that's what the stepped wedge design over there. So this requires us as a team to work very promptly and work with very, very messy data, and also allows us to do these dashboard development. I wanted to mention about this is because this is actually supporting some of the design. So what I mean by that is this dashboard is not just merely showing where the disparities might occur in terms of the census block areas in Harris County, but we have built a number of functions over here to suggest a different design. What if you wanted to select 3 different census block groups for intervention? What if you want to do a complete random sampling? What if you wanted to do some different census block groups that have a better separation, so they are more separated in distance? So this is a real time where we could show the analytical results to the implementation team to help them better do their work on the ground, and also improve the overall communication and communication efficiency. And through the other work, we also have actually developed a novel Bayesian spatial-temporal approach to quantify testing disparity. And this is a work published in American Journal of Public Health, as the whole small error estimation has been a very needed and emerging sort of analytical field that has been identified by the journal in their emerging public health issues. So we have developed methods to really respond to how to best utilize data from a spatial temporal perspective and to support small error estimation. We also just published another one actually doing adaptive geospatial analysis to increase testing and vaccination uptake in this group randomized trial. So this is our kind of a new approach in doing cluster randomized trial, but using census block group or census tracts as the unit. So what is some of the technical challenges? What's the best way to do so, and in a dynamic fashion? We have also been working a lot with Hispanic Health Research Center. And what I'm showing you here is a number of papers that focus on very different applications. We have the publication in talking about individual and community social determinants of health associated with diabetes management in Mexican American population. And through COVID, we have also looked at census tract patterns and contextual social determinants of health associated with COVID testing, vaccination, and identify disparity, and also about some of the more improve of dashboard for communication, as well as some of the pediatric populations from the Texas-Mexican border. Finally, just a couple words about the environmental exposure. We actually have a lot of new data set that coming from satellite imaging data. They are massive, they are messy, but they have really been used in understanding the environmental exposure and health outcomes. And particular one we have been looking at is using these data for the artificial light at night, which has been actually established to have adverse association with a number of disease outcomes, include sleep deficiency, cancer risk, mental health, cognitive decline, and others. So when using some of these data sets, we have the ability to link them and analyze them and understand their association, and also in terms of their spatial and temporal patterns. And with that, we also develop an interactive dashboard, which is actually live, that allows us to look at more granular at Texas level in terms of this novel exposure measure and how we can identify some counties that are experiencing a excessive exposure or above the average exposure. We have also developed a lot of tools to look at cancer screening rates, and this is using the national data to look at how we're doing with cancer screening rates. And this is to look at some of the social vulnerability and the social determinants of health related to breast, cervical, and colorectal cancer screening. And similarly, accompany some of the analysis is this interactive dashboard to allow users to see different regions or different disease outcome. And hopefully we'll build upon this for some simulation models to look at how the cancer screening rates may relate it to some potential interventions. And the other part of the recent paper we just published is looking at some of the chronic disease burden. And this is the work where in the past, we tend to look at chronic disease outcome or chronic disease one at a time. But by using some of this national data where they provided a number of chronic disease measures and behavior outcome measures allow us to look at this together. So we actually look at over 26 different measures of chronic disease and behavior. So we can create some of this index to capture where this is the area that has the highest disease burden and where the areas that start to showing the highest increase in disease burden. So help us to decide where we should do interventions and how these hotspots may relate it to some other social determinants of health. And again, similarly, for a lot of the potential users in Texas, we have a dashboard to allow you to look at more granular level for data that's specific to the state of Texas. So with that, I think I'm going just to end. We do have a website. You can scan me, and which will take you to our center website. We have many different projects, and what I listed over here is really the projects where our center faculty members serve as the PI or MPI. So we're doing a lot of collaboration work to support other centers, but at the same time, we are also having these projects where we design or we aim to improve the methodological work related to how to best utilize the spatial temporal and spatial temporal data analytics. And I have to acknowledge all the funders that we have. And with that, I'm going to turn into the next speaker. Thank you very much.
Thank you, Dr. Bauer. And we'll do the same thing. We'll have questions afterwards. So our next speaker is Dr. Jane Hamilton. She's an associate professor and the Felice Department of Psychiatry and Behavioral Sciences at UTHealth Houston. She co-directs the Center for Behavioral Health Equity and Outcomes Research, focusing on mental health quality, utilization, and outcomes. Dr. Hamilton's research includes early intervention in mental illness, patient engagement, and behavioral health equity. She's conducted federally funded research on evidence-based mental health and substance use interventions aimed at achieving health equity among vulnerable populations. She's a licensed clinical social worker and oversees clinical training and education outcomes for providers on her behavioral health training and service delivery grants. Welcome.
Thank you so much. It's a real honor to be here, and thank you, Dr. Fernandez, for inviting me. So I wanted to start out talking a little bit about the emerging issues and achieving really the barriers that we need to overcome to achieve population health and behavioral health. So first of all, when we talk about behavioral health, we're talking both about mental illness, mental disorders, as well as substance use disorders, but we're also moving more towards overall psychological well-being. So to achieve population health and behavioral health, one of our biggest barriers is really going beyond traditional clinical care. And, so looking at the population as a whole, as the patient, and really using more of a multi-level, multifaceted approach that focuses on prevention, early intervention, evidence-based services, delivering psychosocial interventions with fidelity, and also addressing social determinants of health. So what is this urgent need? So we have enormous systems challenges. As I'm sure many of y'all who are in medical care, public health are very well aware of the challenges that we face. The primary one being barriers to accessing services, particularly among people who are seriously mentally ill, who may be homeless or experiencing some other barriers. Also improving the quality of care and equity. So one of the issues we really face in mental health services, so my background is in being as a therapist, and I have a PhD in health services research from UT School of Public Health, but really not only delivering services to the population, but ensuring fidelity, high fidelity mental health treatment, because currently we are faced with low recovery rates, disparities in outcomes, especially from more vulnerable populations, and provider shortages. So that's one of the reasons we're starting our UTHealth Houston School of Behavioral Health Sciences is to reduce provider shortages in Texas. So as y'all can see, that in Texas currently, 98.8% of counties are experiencing behavioral health provider shortages. And that includes all types of providers: psychiatrists, psychiatric nurse practitioners, licensed clinical social workers, clinical psychologists, substance use counselors. There's shortages across all behavioral health profession roles. And as y'all can see with this graph, it's only getting bigger. So by, I believe, 2036, the projections show that we'll be faced with 36,000 less providers than needed to effectively deliver mental health services in Texas. So my department chair, my boss, Dr. Jair Suarez, has started the School of Behavioral Health Sciences, and we aim to address, our primary aim is to address critical workforce shortages in Texas. And we'll do this by developing and educating the next generation of mental health professionals. And a focus within the school will be on interprofessional training. So this will be the first school of its kind to bring together every level of the behavioral health team and to train them together to address these salient issues. So I also wanted to talk a little bit more about my research and some of the areas that I'm particularly interested in. And so my work is really centered on moving mental health care out of the office and into the community. And so I've had several grants and several of my trainees that are here today. And so I came across this policy paper when I was working with the University of Houston Graduate School of Social Work and our mental health authority, the Harris Center for Mental Health and IDD, which y'all may have heard of. And Dr. Sharmili Roy, who is a graduate of our health services research program at the School of Public Health. So we evaluated the implementation of community-initiated care. It's a new model that came out of Harvard to train lay people to intervene in mental health. And we were having a lot of barriers because it was a very ambitious project that I think was targeting many zip codes in Houston that had many different needs. So we came across this policy paper that I feel like really summarizes a lot of the interventions that are needed to move care out of the clinic. So one of them is really strengthening the ability of community members to respond to people's mental health needs. So y'all may have heard of some of these interventions. I think many people at the School of Public Health are involved in community health worker interventions and peer training. Mental health awareness training has been strong in Houston for a long time, as well as pastoral counseling. And then the community initiated care, which Dr. Roy has a poster on, is more looking at the lay community members navigating people into care. And so this is a promising intervention. Also looking at areas where access can be expanded into the community. So schools, I started out my career many, many years ago, over 20 years ago, as a school-based mental health provider. Now my work centers on delivering behavioral health treatment and homeless service settings that have included libraries. One program I'm particularly interested in that I would like to see implemented in Texas, it's underutilized, is the Pearls program. It was developed by the CDC. It's been implemented in, I think, 18 states. And it was developed at the University of Washington, the Department of Psychiatry and the School of Public Health, and it delivers depression care at home to aging adults that are homebound by community health workers or other paraprofessionals, and it's highly efficacious. And so we're writing a grant to do an adaptation of this intervention to deliver it to people that are aging with HIV. Also permanent supportive housing and assertive community treatment, which is currently delivered by the Mental Health Authority. So my current work focuses on delivering evidence-based services to people with serious mental illness. As a postdoc, when I left the School of Public Health, I went to UTHealth Harris County Psychiatric Center as a postdoc, and I started doing a lot of research with electronic medical records that no one had looked at them for 20 years. And so what I found is that being homeless was one of the biggest predictors of readmission. So I decided, okay, I do love informatics and electronic health record research, but I'd also like to get back into some clinical service delivery and do have some of my own projects. And so we applied to the Substance Abuse and Mental Health Services Administration. And so in 2018, we were awarded a $2.5 million grant. We now are in our second one, so we've had a total of $5 million. And I had learned about this intervention. I had watched a video through the University of Pennsylvania's medical school Department of Psychiatry. There were some researchers there that were delivering CBT to homeless in homeless shelters across Pennsylvania. And they were really reducing rates of homelessness. So I said, okay, we're going to try this in Houston. And so I started working with, we have a really wonderful, it's the U.S. Department of Housing and Urban Development's continuum of care. I approached them, and like currently there was not evidence-based psychotherapy being delivered in Houston. So we got funding. We started our project in 2018 at the Beacon. So we partnered with Christ Church Cathedral, where I went to church, and like some of y'all may know Dr. David Buck. He helped me get this off the ground. But we used shared decision-making, recovery-oriented cognitive behavioral therapy. We linked to psychiatric medication management through the Harris Center, to primary medical care through the Harris Health System. We used an evidence-based program through SAMHSA to improve access to SSI and SSDI, and we provide linkage to supported employment and housing assessments. We do data sharing across the HUD COC, and we have a community advisory board and resource sharing. So these are our goals, to serve 1,000 people. I'm running out of time, but so far to date, we've served 650. And through our implementation science methods, we work with the Beck Institute in Philadelphia. We use these CBT strategies. We have adapted all of our activities to be low literacy and visually engaging. We had a small grant from the American Medical Association, and we developed a psychoeducation manual. Just to show you a couple of outcomes, we collect data very systematically in an EHR we built ourselves that's housed at SBMI. And so starting out at baseline, the entire sample meets criteria for PTSD, but by the 12th CBT session, we have these dramatic reductions with the sample not meeting criteria. We're a patient serum model, so we also measure the patient's perception of their own mental health recovery. And so as you can see, we have increasing rates over time through the 12th session of patients reporting that their own perceptions of their recovery are improving. So we use a portal that SAMHSA houses that Mathematica administers. So these are our quality and outcome measures. So we've had 229% improvement in housing stability, functioning, as y'all can see, in everyday life, perceptions of social connectedness, which we're particularly proud of, improvements in reductions in psychological distress, community retention, not as great reductions in substance use, but we are a harm reduction program, reductions in homelessness, psychiatric hospitalizations, inpatient substance use treatment, and criminal justice system involvement. And so we have expanded. We started a program with the Harris Center, providing a step-down program from HCPC that we have provided the therapy for. We also do the cost analyses. And so for people that have completed this program, we have very low rates of people returning to having a jail booking within a year after leaving our program, their program, as well as we have overall reductions in the aggregate, regardless of whether people completed the program or not. Just being in this step down has shown to dramatically reduce both jail bookings as well as psychiatric rehospitalizations at HCPC. So we did a recent cost analysis, and we found that in the 3 years examined, that we have $1.2 million in cost avoidance, and not just based on rehospitalizations at HCPC. So we're very proud of our results. And anyways, we'll answer questions later. So thank you.
Thank you, Dr. Hamilton. Don't often see things like 200% improvement. So congratulations. I'd next like to introduce Dr. Hongfang Liu. She's a professor at McWilliams School of Biomedical Informatics and serves as the Vice President of Learning Health Systems at UTHealth Houston. She leads research in the Center for Translational AI Excellence and Applications in Medicine, otherwise known as Team AI, cool name. And before coming to McWilliams in 2023, Dr. Liu was the Dr. Richard F. Eslander Professor of Biomedical Informatics at Mayo Clinic and directed the Biomedical Informatics program at Mayo Clinic Center for Clinical and Translational Science. And she also led the Cancer Data Science and Informatics at the Mayo Comprehensive Cancer Center. She has a broad range of informatics expertise, including artificial intelligence and informatics in healthcare, computational biology, and bioinformatics and biomedical data science. You can read about all of her amazing awards in the program. But we were lucky enough to get her here through a CPRIT Established Investigator Recruitment Award. Welcome.
So, so I'm representing the McWilliam School of Biomedical Informatics. Unfortunately, I don't have the overview slides of our school, but just to give you a snapshot, our school have about 60 faculties with 3 departments. We have Department of Clinical and Health Informatics, which is have a lot of collaboration with across the schools. And we also have health data science and artificial intelligence. That's where I belong to. Then we have the School of Bioinformatics and System Biology. We do a lot of things related to biomedical discovery. And we also have 9 centers, and 7 of them are research centers. So I'm here basically trying to take this opportunity to introduce our center as well as the vision we want to see regarding the learning health system. Really hope to reach out because I'm relatively new to this UTHealth Houston. And in order to deliver in population health, you have to be here for 5 years. And so this is the website. As I said, our center is called Team AI. And I will talk a little bit about why it's so important to think about this through the team perspective. We specifically call out the team in our name, and we take like 3 months to figure out how to call our center. So this is the mission of the center. Really, it's try to grounded relate to quality improvement metrics. I really want to say, how do we make sure those technology innovations and advancements in biomedical and the health side to be really to creating the healthcare of the tomorrow. The purpose is to try to have patient experience improved, better health achieved, healthcare cost reduced. Of course, overall, try to have better health for everyone. So those are the tagline of our center, which is Raise AI to Care. The emphasis is on the care component. So the R stands for the methodology innovation. A stands for how do we ensure we have infrastructure ready for the AI to be able to function. C is related to how do we really leverage the data, infrastructure, and the technology to facilitating, accelerating this. Most importantly, we want to make sure that discovery can become impact. And lastly, we truly want the tomorrow's healthcare to be excel. And many of you touch upon the learning health system. And for this audience, we don't need to talk more about it. Every healthcare system, to me, it's a learning health system in general because healthcare itself is actually evidence-based, and we keep learning from our data. But historically, the data was captured more in the expert view, and expert summarize the experience that become evidence through trials, through this rigor process. Nowadays, we know we have digitalized a lot of our society, including publications, including patient care, all those kind of data. We cannot just simply say we still go back to our original way of do evidence-based medicine, which is a very long process. The digitalization gives us the opportunity to accelerate that process. So just, this is a go back to, there's another hot concept, which is hardcore digital twins. This is basically in the digital world, we digitalize our society, digitalize a lot of things we do, including healthcare. And so every of our activities become digitalized. You have a digital replication of your actual events, of your real world. Can we leverage such a technology to facilitating data-driven decision-making? You can say learning health system is a concept, it's a use case of digital twin. And this review just to say in this kind of technology is that we should not try to abandon the data we collected. We are digitalized. We know that we should not, not leverage technology, not leverage data to accelerate that process. So this is what we envision as the evidence-based medicine for the healthcare of tomorrow as the paradigm where the real-world data is a big chunk of that evidence-based medicine component. This is including evidence-based service intervention in population health. In our center, the approach is taking very strongly aligned with three things we focus. One is needed to be a team science approach. It cannot be alone because right now we're really not happy with how the AI industry talk about it, because a lot of them was talking about, I want to replace something, but not really try to say we are trying to empower something. This is actually caused to me a significant issue. So the structure of translation or leverage technology for that need to be in the team science. Secondly, the process need to be translational science. We don't try to say we create innovation. We want you to try to find a problem for me to solve in the population health side. It need to be, really address the real world problem face. And the only way to achieve that is actually through team science collaboration, because as a technology methodology person, we don't know what are the problems faced in the population health side. We need to reach out, work as a team. And also, this is the translation process is also the something which is trust and also scientific rig and transparent. Those things are factoring there. Lastly, of course, anything we need to ensure the data there is talk about the story. So I think this is the team. I actually migrated my team from Mayo here. So basically, all the team members are currently here, and we are building a strong methodology, a centerpiece, but with all the collaboration across. I will go quickly. This is as the established investigator world that the project is a collaboration across. So this is I call Discover Wonder. And we do also have data. We have tooling on top of the data. And this is another effort I involved with UT Systems, try to create a health intelligence platform with the real data. So this is the old slide. The new version will have the real EHR data from the systems here. I think just quickly through, there are a lot of collaboration we conducted. But this is just showing we're really doing something on the tuning side. We needed to make sure those tuning can be leveraged, used to support the population health. Many independent collaborations. This is another way related to aging-friendly health system. We work with Institute of Aging. That's the last slide.
Okay, thank you. So tremendous amount of collaboration. Thank you so much for your presentations. Now we have time for some questions. Questions, comments? All right. You can just raise your hand and we'll bring the mic to you. I'll start. So Dr. Bauer, you talked about some of the methodology that you use to deal with things like the messy data and the dynamic sort of conditions and during the pandemic. Can you say a little bit more about how your team and your center also helped on the intervention side? I know there's a lot of folks that are here, and you mentioned the JEDI briefly, the just-in-time adaptive interventions, but can you say a little bit about that kind of collaboration? You just have to turn it on. a little button on the top. I can do that.
Yes, I think a lot of this generally we think is how do we turn that data into something information, right? So, thank you so much. So I will just use the red X as a particular example. I think a couple of the particular data analysis needs from that project is the pipeline needs to be very efficient because we don't have the time to wait to several weeks until we get the data cleaned. And if you're familiar with some of the work in terms of spatial analysis, there's always geocoding, there's a data linkage, there is identifying these duplicates, and especially this data is actually the real-time data coming from COVID surveillance. There's actually a lot of these work. So I think part of this is we have to do it very fast, rigorous, and accurate. So part of our work is really trying to bring these information, in a sense, from the noisy data to tease out all the noise and tease out the inaccuracy and bring this data to the implementation science team so they have the good data to work with. So that's the number one. Number two, for some of the design is that we really needed to identify where are these vulnerable populations are. And in this particular kind of stepwise design, the cluster you think of is actually the census block group. So they're changing all the time. So we also needed to know what are the external data sets that can help us to identify the vulnerability. So in this case, we used not just the COVID data, surveillance data, we also use a number of the census data, CDC data, so that we can bring all this data very efficiently to connect to the data we have locally from Texas. So the dashboard we develop is really through a lot of communication with the implementation science team about the design so that we know bring the most effective data visualizations and to help them. And then actually we learn a lot about how these community workers might want to see the data in a way that help them to do the implementation, so that we get those feedback and reflect those to the dashboard to help them do that. So I think some of this work is we learn a lot from the implementation science team as well, how to best visualize these data in a spatial and spatial-temporal setting.
Thank you. And I'll just add that, because I was on that project as well, that so Paula Caccaro, Laura Savas, Belinda Reininger, leading the intervention efforts in the field, right, for the health promotion, for implementation science, they were able to leverage this data that was provided by Dr. Bauer's team to create tailored messages. So when there were certain groups, for example, that we knew weren't getting tested, those messages could be created specifically for them, and the community could get involved in giving advice about, well, where should we go for these groups? So it's a back and forth, and that's why we called it a just-in-time adaptive intervention, but it wouldn't have able to be either just-in-time or really that adaptive without that collaboration. So thank you, Dr. Bauer. Okay, Dr. Hamilton, just a quick question for you. I'm just wondering, so you talked about tremendous impact, right?
Mm-hmm.
And I'm wondering if you've thought about scaling. Like, how do you take the lessons learned from your innovative programs and make it available?
So that's such a good question. So I think, one of the challenges that we're faced with in psychotherapy is having to ensure fidelity. So I actually have to record sessions and rate and, monitor. So one of the things that we've written a grant for that we haven't gotten funded is to use chatbots or some kind of AI to kind of more train and monitor fidelity. One of the other things that we do is in our electronic health record that we built through SBMI, we have a therapy note that actually the therapist ensures fidelity. So I think that's really the key from an implementation science perspective, if I'm making sense, is that if we scale, we still want to keep the quality that we feel like we have. And how do we do that? And also, how do we train providers beyond like the services because we provide our own services. So I think that's ultimately the challenge. So that's something I'd like to talk with you more about. And I've talked to Sarat about is how can we get a grant that we can do more coaching in the community and even maybe go statewide, if that makes sense.
Yeah, absolutely. And you know, we often talk about population health impact as being both effectiveness and reach, right? And sometimes you have interventions that have a big reach, but they're not as effective, and vice versa. And I think thinking about things like implementation fidelity and putting tools into place that can help make that happen can maintain effectiveness and help increase reach to improve population impact. So thank you. Did I see a question? Somebody had a question? No? Okay. Over here. Yeah.
This question's for Dr. Hamilton. And I'm curious to hear a little bit about your new school that you guys are developing, the behavioral health, and particularly because you mentioned that you're doing interdisciplinary training. So one of the biggest challenges, I'm here from the Texas Association of Community Health Centers, and we're big on integration of services across all the staff. What seems to be a huge challenge, though, is actually that interdisciplinary, that really making it happen interdisciplinary, because of the way people are trained, or maybe the way we're not trained. So if you can just make a few comments about how what your approach is to that interdisciplinary training, and including how you bring in medical, dental to behavioral health, or behavioral health into their services.
So that's a wonderful question. Thank you for asking. And I think I need to ask my chair probably can provide much more. The dean, he's the dean of the new school. But I do know that we're going to be using evidence-based interprofessional training models, and then also just having all the different behavioral health providers to start under the same roof, and attending things like the same training together, grand rounds, really doing case, I think simulations, case staffings, those sorts of things, but having all the different disciplines together would be very innovative. And so that, I think those are some of the things that because we're just starting the new school, but I think that will be the focus. And then, we have also inpatient and outpatient services, as well as all of our community partners. So I think focusing on that as well, and then bringing in the other schools to make it more interprofessional. So,
and I would just comment, and thank you, Dr. Cruz, for asking that question. That I think that as the curricula are developed in the new school, that hearing from people like you, people who work in organizations that have these needs, and hearing your thoughts about what are some of the competencies that are going to be important in addition to what you already mentioned, which is the ability to work collaboratively. I think that would be really helpful.
thank you.
So thank you. Question. Dr. Liu, you talked about a number of very impressive initiatives, and you've only been here for a few years, already won additional awards, and have managed to foster a lot of collaboration. I know that one of the efforts that you and Dr. Balasubramanian are engaged in is trying to build and foster this learning healthcare system collaborative, and I just was hoping you would say a few words about that.
Sure. So I was being appointed as a VP for learning health system, and then I was trying to figure out exactly how these things will work, and then I was noticing that so many efforts can be defined as a learning health system. So it's really needed. First, we needed to know how to get those people together. So we do plan a retreat this month to get the team together and figure out how we work as a team, moving things forward. Specifically, I was telling the president before, is that I don't want to create another entity, because the thing is that I don't think trying to make a community together by creating one additional entity does not work. It's how do we both, just like Office of Population Health Council, this event, it brings people together. I think in the learning health system side, we also need to bring all the people together, maybe combine effort to move things forward.
Thank you. Thank
Yeah.
you. That's great. Other questions? Okay, well, thank you very much. We're going to move to our next session. Thank you.